So we've reached the question and answer phase. I'm going to turn this over to Kate Parberry, who will sort of describe a little bit about the logistics of this. Kate?
Hi, guys. We are now more than happy to answer any questions. Dr. LoSasso is available. We have a couple that were pre-emailed in, and so I'm going to ask Dr. LoSasso those questions. These people could not attend right now. And then after that, you can either chat with us. If you look down at the bottom of your screen and hover over your participants bar, you should be able to hover over the More button and click Chat and ask your questions that way. Or if you hover over where it says Participants in the bottom middle of your screen, you should be able to click on the word Participant and then raise your hand in the upper right or left-hand corner per these instructions. So I'll leave them up on the board for just a second while I ask a couple of questions that were pre-emailed into us. Dr. LoSasso, how far in advance does testing need to happen in order for the surgery to be approved and proceed? So if you were going to schedule a pre-interview with Allison and then 2 or 3 days worth of testing either with you or in a person's home state, when does that need to occur before the surgery?
That's a great question. So most insurance companies have a 6-month sort of time limit on the results of a given battery of tests. So one should keep that in the back of your mind as you plan for testing, knowing that if there's a chance that you may want to act on those results and use those results for the purpose of insurance approval, that there is a time limitation on those testing results of 6 months. So the short answer would be, don't do testing outside of a 6-month window from when you may, not that you must, but you may wish to proceed with approval and surgical correction.
Along those lines, Dr. LoSasso, as we know, a lot of people took a year off with COVID. Coming up, if people would like to schedule, for example, Thanksgiving break, winter break, spring break, are those timelines possible? We do have on our website travel guides and recovery maps. When do people need to get on testing at the bare minimum to get on a schedule with you or some other specialist?
Great question. So the testing, if it's done sort of sequentially as most people experience it in different parts of the country, it can take upwards of 4 to 6 weeks to get all of those appointments not only scheduled but completed. That's still, if one was contemplating doing a correction before the end of the year, that's still doable if one is moving forward with the testing right now. So if there's a person out there who feels as if they want to address their chest wall deformity in the calendar year of 2021, I would say it would be imperative that that individual begin the workup within the next 2 to 3 weeks, because once the testing is done, then that needs to be processed. That then needs to be sent on to the insurance company for their approval and then scheduling happens after that. What I try to do with patients who come from a distance, and I do have patients coming from all over the world to me, what I try to do is help them with timelines. And often what that means is I'll reserve a time which would be within reason for them to complete the workup and move through the insurance protocol, just so they have a time that they know is reserved for them, waiting for them at the end of that process. So my office and the schedulers in my office really try to work towards helping families with very narrow timelines to get the workup done in an expeditious way, and be able to schedule their procedure in a shorter period of time. But again, I think if you're really looking at the end of the year, it would be important to start your workup, right now.
Dr. LoSasso, another question that was emailed in, and then trust me, I'll get to everybody on chat as well shortly. We get a lot of questions from people who have very younger children, and they want to know when they should begin to evaluate their children who seem to have a trait for Pectus excavatum. What is the protocol on that? How early are you willing to talk to people?
I've seen patients, in the nursery with the overt signs of sunkenness and Pectus excavatum, and so I don't think there's any hard, fast rule about how young is too young. I think whenever a patient or family recognizes that there's a Pectus deformity, that I am more than willing to see that patient and begin the educational process of the family in particular as to, what this means in the short term, in the developing child, and what it might mean later in the patient's life when a more extensive evaluation would be indicated. I just find that families are so appreciative of the education that they receive from sitting down and discussing their individual loved one after I've been able to examine them. And I think it really helps most families to feel less stress because they know more about the condition and know that there's nothing that is life-threatening about the condition, and that they should treat the child as a normal child and encourage the child to be as active as possible. So I just find it's helpful to sit down with families whenever they're open to that conversation, no matter how young the child is, and allow me to educate and to evaluate the patient. Once that contact is established, then we can talk about the frequency of reevaluation. Generally, if the child is, 5, 6, 7, or even 2, 3, or 4, I'll see those patients at biannual visits, meaning every other year, until they get to be about 10 years old. And then at 10, depending on the severity, I'll tend to see the patients yearly until it's clear that the workup is indicated and that the results could prompt an intervention should the results so indicate. So that I help the family with in making that timing decision regarding when it's important to move forward with testing. So I think establishing that clinical contact, establishing a relationship between the family, the patient, and myself and my team is always so helpful in terms of what's to come later in life. So we're here to begin that process whenever families are interested in doing so.
Dr. LoSasso, we have 2 questions from HotR, and I apologize if I mangled that name, but if you also would like to unmute yourself and ask them in person, I am more than happy to allow that. He said, good evening, many thanks for the invitation. Dear doctor, do you recommend rehabilitation after the Nuss procedure? And when and for how long can we continue the rehabilitation program? I'm going to interject here before Dr. LoSasso does. We do have, and I'm pasting the link in to past webinars and specifically a video about rehabilitation on our website. And we will work with out-of-state rehabilitation groups as well, but we're pasting that one in. And then you are unmuted if you want to ask your own questions. And then the second question after rehabilitation was, can you fix the bar with 1 or 2 stabilizers?
Great.
So rehabilitation and stabilizer bars.
Right. So rehabilitation and some sort of technical questions about the procedure. So okay, let's start with the rehabilitation. I am a super enthusiastic advocate for physical therapy after the Nuss procedure. And this is regardless of whether or not a patient is having some discomfort during those early weeks after the procedure when you are recuperating at home. I think controlled movement is vital in the recovery from the Nuss procedure. So early on in my experience, I solicited the expertise and advice of some of the leading physical therapists in San Diego, where I practiced for the first 30 plus years of my career. And I was fortunate enough to work with some excellent physical therapists, and together we came up with a comprehensive week by week plan for physical therapy. And it was really quite a detailed protocol that involves specific exercises done in a specific sequence over the course of many weeks. And I've used that protocol for probably 15 years now. And I've been so pleased with how much it benefits my patients to assist them through the recovery phase of their journey. And so I'm a big proponent of it. It has to be done in a very controlled and mindful way, respectful of what was surgically done. So that's important for the physical therapist to have some sense of what's a Nuss procedure, what was done to the patient, where are the implants, how does one do the physical therapy without causing any injury or problems for the patient. That requires a conversation and a fund of knowledge for the physical therapist to possess, and for a conversation to occur between some member of the treatment team and the physical therapy program or practice that's going to be providing that phase of care. So I think it's uniformly a beneficial and vital next step in the care plan, but it has to be done in a very, very specific way with a lot of oversight by the team that's providing the surgical care. As far as 1 versus 2 stabilizers and 1 versus 2 bars, those are intraoperative decisions that are specific to the treatment that a given patient would require from a given provider. So I'm not going to give you any hard, cold rules because I don't think they really exist. But let me give you this sort of 30,000 foot view of the Nuss procedure. Your objective as the surgeon is to lift the chest wall off the heart in a way that adequately lifts the chest and maintains the stability and security of the bar or bars, let's just say the implants. So that's the North Star. That's the holy grail of doing the Nuss procedure. And how you accomplish that has everything in the world to do with the experience and technical ability of the individual surgical provider. And that comes with just doing the operation over and over and over again across a spectrum, an extensive spectrum of severity and ages. And that's what you get by going to an experienced surgeon. So that's part of what every patient and family needs to know. They need to know that it's vital that whomever they entrust their care to, that individual has done a significant body of work doing Nuss procedures across all ages and all levels of severity. If that is the case, you, the patient, or you, the parent, can rest assured that the individual doing the operation will make the right decisions, because there's a lot of decision making that happens intraoperatively. Where the bars go, how the bars are bent, how the bars are secured, are all part of the fund of knowledge that an experienced chest wall surgeon brings literally to the table. So there's wide variability. I want that to be clear to those of you out there, thinking through who you want to entrust with your care. There's wide variability about how individual people bend and secure their implants. But you, the patient, need to understand very thoroughly what that individual is going to do in regards to shaping and securing the implants. And you need to be comfortable that the plan makes sense to you and that you've vetted the provider with regards to their own results in doing it in the way that he or she is suggesting it be done. And don't spare any detail. It's important for you to ask those questions and be comfortable with the answers that you're provided.
Dr. LoSasso, we've mentioned multiple times tonight that in a lead up to insurance and timing, that testing has to be done X amount of time ahead and not too soon and not too far away. We do have a specialist in the office, and if you reach out to Kim, our patient coordinator, or to Allison for a free Zoom evaluation, we can discuss insurance and how those things will go forward. It doesn't necessarily mean insurance is going to pay for all or nothing, or you're ruled out one way or the other. It's just to get the ball rolling, correct?
That is correct. And the specialist in the office, let me go back over that again. So for scheduling, it's Georgia and Lynn. For insurance questions, it is Linda. And for just a complimentary evaluation and a wealth of knowledge, I mean, this is the best deal going, is to sit down and spend 30 minutes with Allison Tan, the physician assistant who works with us, and let her spend a little time with you to understand better what your condition is, how it's making you feel, what workup, if any, has been done, and what working together with us would be the next steps necessary in order to proceed in an orderly fashion in the process. So Allison is available to do that, and that's free of charge, in addition to the other people within the practice. And then, of course, Kim is there to answer any inquiries through the website, either by calling the website number or by emailing the info at email address that's listed on the website. In addition, there is a ton of information. There's a ton of great content on the website, which is nussprocedure.com, from more information about anatomy and physiology, some very good information regarding how the operation is done by me, and a lot of the postoperative care that's necessary when the procedure is done, which includes pain management, physical therapy and rehabilitation, and then the multitude of questions about what does my life look like after the procedure in terms of things I can and cannot do. So there's a ton of that content, and there's also the many webinars that we've done for the Pectus community that are archived that deal with a multitude of subject areas. So
Dr. LoSasso, we have a great question related today to this entire webinar. Matthew, if you want to unmute yourself, if you're still in the room, I'll allow it. I've asked you if you want to, go for it. Otherwise, I'm just going to read the question. What percentage of patients go through testing and the results indicate that corrective surgery is not medically necessary? And thank you for your time very much for your time this evening.
Oh, I think that is a great question. And I would say that it's the distinct minority that have testing and don't qualify. And the reason that is because people in the Pectus community in the 21st century are very fairly knowledgeable, are I would say very knowledgeable. And so they've almost self-diagnosed and have, through seeing pictures of other people that are on websites and social media sites, they can sort of judge for themselves, do they have something that looks similar to what went on to be corrected in a given individual that they've reviewed the case history on. And so they often do a great job of identifying themselves as a pectus excavatum patient with a deformity that is truly worth working up. My point that I want to leave with the audience is that if you have a pectus deformity of any variety, you need some evaluation because you may have some other associated issue that is worth knowing about. So, I understand the question that the gentleman posed. I would
And
say,
Matthew's unmuted, so he can
so
feel
I
free
would
to
say
continue this conversation.
Matthew's question is a good one. It is the distinct minority of patients who don't exceed the 3.2 threshold. But having said that, even if you do exceed that, there are some people who don't want surgery. And I'm always very respectful of people who, knowing all that they need to know, come to the conclusion that an operation isn't something they wish to pursue. I hope that answers your question, Matthew.
Can you hear me?
Yeah, I can.
Okay, it's actually Mike Greenhouse. Matthew's my son. It's just, I think we're using his Gmail account, so that's why.
Oh, okay, no problem. No problem.
No, that's great. We were just wondering, about going through the testing, and then what percentage of people after that going through that would maybe not not need to have it corrected.
Yeah, well, I mean, the point is here, there is no obligatory decision.
Right.
There's the decision that you and your family and your child, take away from the process that's most important. And I don't want any family or patient to feel any pressure by doing the testing. That keeps so many people from the testing, right? They're afraid of what the results might imply, but it's better to know the full extent of what's going on within the body because of the sunken deformity than not knowing. And you always have the option, once knowing, of not surgically acting on that information. But you have the information, and that's the most important thing.
Thank you so much.
You're welcome.
Dr. LoSasso, are you willing to meet with people before testing?
Of course. As a matter of fact, before the world of webinars and telemedicine, that was really the most common pathway to testing, would be that you would come and see the provider, a rudimentary exam and history taking would occur, an explanation of what Pectus is and isn't would then be provided, and then testing would be arranged and an explanation of the testing would be given. That would be all part of the initial evaluation of a Pectus patient. But as a result of the technological advances of Zoom and telemedicine and the pandemic, much of that initial outreach occurs in this fashion. The testing is ordered after a telemedicine evaluation based on how the patient appears and some history taking that is achievable through this format. And then testing is ordered, or it's arranged that the patient will come to New Jersey and have the testing done here and then be evaluated in my office. So there's a multitude of ways of moving through the early phases of the process. That's what's important for every person out there to understand. And we've got the luxury now in 2021 of finding a way of getting it all done and the information exchanged between myself and a prospective patient without necessarily having to physically meet for that initial evaluation. So I think that's a real advance, and it helps patients immensely, especially those who want to come to me from a distance.
Dr. LoSasso, we have another question. And this one, HotR, you might have to unmute yourself to ask it better than I can via chat, if you're comfortable with that. But what's the time interval between first and redo operation in case we have a failure in the first operation? So Dr. LoSasso, how many failures do you have? And then how long would one have to wait?
Well, that's a great question, and that is something that I would rather talk to the specific patient about, because there's no simple answer to that question. I have been involved in redo operations. They are very rare, thank goodness, extremely rare. They do occur. I've never personally had to reposition or reoperate for the purpose of implanting more bars or taking bars out, or rearranging where bars were located in a given patient. I've just never had to do that in over 20 years. I think part of that is because I was trained so well and directly by Dr. Nuss, and then what I personally bring to the table when I do the operation, I just haven't found the need to have to revise my own patients. However, I have had the challenge of patients coming to me having not achieved an optimal result with situations which were somewhat precarious. And in those instances, I individualized the therapy to maintain safety and to optimize the outcome, given that the situation was exceedingly suboptimal at the time that I met the patient. But there is no simple timeline answer to that individual's good question. It has to be individualized. You have to know what the problem is, and then you have to know what would be the safest way of fixing that problem. And then the timeline question becomes a little clearer once those other questions are understood and answered.
Would anybody else like to ask any questions? I'm gonna leave it to Dr. LoSasso for closing if we've answered all questions.
Well, I just want to thank everyone who tuned in tonight. It's such an honor to be able to come to you on a monthly basis and try to provide you all with the information that I think is extremely vital for the community to have at their fingertips when they are making the exceedingly important decisions regarding their own care or the care of a loved one. So I just am so thankful that I have this opportunity to spend with you. I and my staff are here for you if there's questions that should arise as you go further along in your journey, your individual journeys. And I just want you to know how important it is for us to continue to provide you with good information. We have some ideas for future webinars, but if there's something that some of you out there really want to know more about, and you think it should be a topic for a future webinar, please feel free to either email us on the info line or call the office or call the number on the website and talk directly to Kim or to Allison in the office, because we're so interested in providing information that you, the community, find useful. So thank you again for your interest in this process of education. And I look forward to our next time. Stay safe, and we look forward to speaking to you all again. Good night.
Thank you all. I did just also launch a brief poll. If everybody who's still available in the chat room could take it, that would be awesome. And it will help direct our future webinars. Thank you, Dr. LoSasso, for your time this evening.